Timer is on, and here is your question. Right, if you have read and understood, let's begin our session. Can you tell me what are you looking at?
This is barium mean of the barium swallow of the showing the esophagus.
Yes. Can you identify structure number 3 over here?
This is the barium in the esophagus.
Very good. And
It
number...
is showing the upper. Yes.
Yes, yes, please. Showing upper?
A, this is the
Upper
A,
esophagus.
this is the cervical esophagus. Yes.
Yes. Can you please identify number 6 over here?
6, this is the tracheal margins.
Very good. And 7 over here?
7, this is the
Piriform recess. Yes. Okay. Moving on to picture B. Can you tell me what 1 is?
Yes.
Number 1. Can you please identify number 1,
This
please?
is the aortic arch impression
Yes.
of the esophagus.
And number 2, please.
Of the esophagus.
Yes, number
This
2.
is the arch of the aorta.
Yes. Okay, number 3 over here.
This is the barium in the esophagus.
Yes, good. And moving on to picture C, can you tell me what number 8 is?
It's the diaphragm.
Yeah, or stomach. Okay, number 5.
Okay. 5, this is the lower part of the esophagus.
Yes. And 4, please. 4, where is 4? Yes, 4
the
is
diaphragm.
here. And 9, please.
This is the stomach.
Okay, talking about esophagus, can you please tell me at what level it begins and at what level it ends?
It is begin at the lower end of the margin of the cricoid at the level of C6.
C6,
It is
okay.
end at the level of T11.
Okay, opposite. Okay, opposite T11. Can you please tell me the blood supply of esophagus according to the segments or the parts?
The upper part of the esophagus is supplied by the inferior thyroid artery.
Yes.
And the thoracic part is supplied by the branch from the aorta, and the lower part is supplied by the left gastric artery.
And inferior.
And the inferior
phrenic
artery.
Yes. Okay, can you please tell me what is the lining of the esophagus? Cell lining of the esophagus?
It is non-keratinized squamous epithelium cell.
Yes. Okay, can you please tell me how many constrictions there are in the esophagus and at what level?
There is constriction at the level of the pharynx, T6, and the left main bronchus.
Yes.
And at the level of the aortic arch, and when it joins the stomach.
Okay, at esophageal hiatus. What is the total approximate length of esophagus starting from incisor?
It is about 40 centimeters.
Okay. Can you please tell me what is the lymphatic drainage of esophagus?
The upper part is drained in the deep cervical lymph node, and the middle part or the thoracic part of the drain into the posterior mediastinal lymph node.
Yes.
and the lower part drains to the left gastric lymph node.
Okay, can you please tell me what makes an indent on the esophagus?
Indentation, there is
Yes.
the left main bronchus and
Yes.
the arch of the aorta.
And left atrium as well.
And
Okay.
there is esophageal hiatus.
Yeah. Okay, can you please tell me what do you understand by the term Barrett's esophagus?
It is columnar metaplasia of the esophagus
Yes.
associated with adenocarcinoma.
Very good. And how would you differentiate it from eclasia of esophagus?
Achalasia, this is a motility disorder of the esophagus.
Yes.
It is mainly involves smooth muscles
Of lower.
due to it's mainly due to lower esophageal sphincter,
Yes.
increase the pressure, and failure to relaxation.
So what are the microscopic pictures of eclasia? How would you explain it?
There will be hypertrophic of the
Yes.
musculature
Yes.
and loss of maintaining plexus.
Okay, can you tell me what are the complications of perforated esophagus that you can expect?
There will be mediastinitis.
Okay. If a person has esophageal carcinoma, then what kind of carcinoma can person have, and what should be the management?
Sorry.
If a person has esophageal carcinoma, then which part of esophagus is most commonly involved?
It is most commonly involves the lower part of the esophagus
Okay.
associated with adenocarcinoma due to
Yes.
GERD.
Okay, good. Okay, can you please tell me what would be the management if there is esophageal carcinoma in the lower part?
Okay, after history and examination, they will be do some investigations.
Yes.
I will do CT or MRI for staging.
Yes.
Then
What
I will
is called
discuss
the
in
surgical?
MDT.
Yes.
Yes,
What is called the surgical procedure that is done? Okay, what organ are you looking at?
it is the anterior part of the stomach.
Okay, can you please identify the structure number 2 over here, please?
This is the body of the stomach.
Yes, and number 6 over here.
This is the fundus of the stomach.
Okay, and number 18 over here, please.
It is the pyloric antrum.
Yes, and 19 over here.
The pyloric canal.
Yes, and
23.
23.
This is the first part of the duodenum.
Very good. Can you tell me what are the parts of the stomach?
The fundus on the body and the pyloric antrum.
And the pylorus. Okay. Can you please tell me the blood supply of stomach? Both
It's
arterial
supplied
and
by the
venous,
left.
please. Yes.
There is the left and the right gastric artery. The left is the branch of the celiac trunk. On the right is the branch of the hepatic artery proper.
Yes.
And also there is the left gastroepiploic artery. It's the
Yes.
branch of the splenic artery. And the right gastroepiploic artery, the branch of the gastroduodenal artery. And there is short gastric artery supplies the fundus. It's the branch of the splenic artery. The veins follow the artery. There is the right and the left gastric vein, and the right and the left gastroepiploic veins, and short gastric veins.
Okay, good. All right. Moving on to the next one. What are you looking at?
This is the barium meal of the stomach shown in the stomach.
Yes. Can
One,
you?
this is
Yes.
the body of the stomach.
Yes. Good. And then 2, please.
2, this is the greater curvature of the stomach, and
Very good. 3.
the greater curvature of the stomach.
This
The
is
laser
2.
curvature.
Lesser is 3. Okay, and 4, please.
Is the pyloric antrum,
Antrum, yes.
and 5 is the pyloric canal.
And 6,
6 is the duodenum,
duodenal
the
cavity. Yes.
first part of the duodenum.
Yes, very good. Good, thank you.
Thank you.
What type of illnesses are common in stomach?
There is chronic atrophic gastritis,
Yes,
and there is peptic ulcer,
yes,
and there is CA, squamous cell carcinoma, and adenocarcinoma of the stomach,
okay,
and there is gastritis.
yes. All right, good. More questions I cannot recall. Bell has also gone. Thank you so much, Dr. Mohammed. Good. Here is the question. Right. If you have read and understood, kindly begin your station.
Okay, ma'am. Hello, I am Mohammed Al Ayan, one of the surgical doctor registrar for working for Mr. Max in Charity Hospital. I am calling to speak Mr. Max as a hepatobiliary consult to ask him advice about patient post-cholecystectomy complaint of abdominal pain and nausea and tachycardia. Can I check that I am speaking to Mr.
Yes. Can you proceed?
Yes.
Hello?
Yes,
Yeah, can you
yes,
proceed, please?
yes, doctor. I am calling to ask advice about 45 years old obese male post-cholecystectomy for this complaint of abdominal pain, nausea, and tachycardia. Done investigation like ultrasound, free float in the abdomen, no common bile duct dilatation, and done full blood count as total leukocyte as 18 and the CRP 15 and the bilirubin high.
Okay. So, what do you think is wrong with the patient? Hello?
Oh,
Yeah.
hello?
Yeah. I said, what do you think is wrong with the patient? What do you think is wrong with the patient? Hello, can you hear me?
Yes. Can you tell what is wrong with the patient? What is happening with the patient? Why is patient like this?
I am calling to advise about this patient.
Yes. What happened to the patient?
Okay. So,
Yes,
what?
the possible
Yes.
happened this patient
Hello?
abdominal pain and tachycardia post for cholecystectomy. I think possible source of bile leak.
Okay. So, what are the possible sources of bile leakage?
Yeah, I think due to cystic duct stump leakage due to slipid cleavage or common bile duct stone and the accessory cyst duct and leakage from the liver bed and the common bile duct injury.
Okay. Good.
Okay. So, and what will be your management?
Yes, I started the management fluid resuscitation and antibiotic and prepare for the blood, and maybe need the ARCB to detect the source of leakage and to put the stent if not available in this hospital now.
Okay, and what is the best method of investigation for this patient? The best initial method of investigation.
Yeah,
Hello?
the best investigation, full blood count, as important WBC and hemoglobin, and urea and electrolyte, and ultrasound to detect the collection, and the MRCB and ERCB to detect the source of leakage as a diagnostic and therapeutic to put the stent.
Okay, so is it urgent?
Yes, to avoid biliary peritonitis.
Okay, so do you need to arrange with anyone?
Yes, with the bed manager of both hospital to discuss creating bed, whether by facilitated discharge or rehabilitation of the patient.
Okay, so you mentioned ERCP. So do you want us to do the ERCP with us, or are you going to do the ERCP before the transfer of the patient?
No, I think first resuscitation and start with antibiotic. If not available, RCB in this hospital can be sent the patient and transfer to another hospital as a hepatobiliary consult.
Okay. Is there anything else so you can? Hello.
Hello.
Oh, do you have anything else you would like to add about the patient?
Hello.
Hello, can you hear me?
Hello.
Hello. Hello.
Hello.
Can you hear me? I said, do you have any other information about the patient?
Can you tell when the blood was taken from the patient?
Yes, taking blood, full blood count and urea and electrolyte.
Yes, when? Why patient has high CRP? Is patient suffering from any infection?
Because the CRP is acute phase protein likely to be raised due to operation. Trend is showing to decrease, and this patient pattern of symptom fit with bile leak.
Okay.
Okay, so you can arrange the transfer of the patient. And but doctor, you did not tell me. Are you doing the ERCP at your hospital, or are we going to do the ERCP at my hospital? What do you think?
We suspect this patient had bile leak. She need ERCB to identify the location.
Okay. Then you can proceed to transfer.
Does the patient has drain in it? Drain in situ? Does patient has any drain? Drain? Does the patient has any drain? Post-op, it's a post-op patient, so is there any drain inserted or in situ already present?
Yeah. No drain. Done ultrasound and the drain insertion. If no peritonitis, monitor the drain. If more than 200 milli every day, done ERCB and stent. If drain inside to wait and watch that till peritonitis and done ERCB and stent and laparoscopic lavage and the drain insertion would repair leak and repeat ERCB after 6 weeks.
Okay.
Okay.
if there are no beds available in the hospital right now, what would you do?
I will alert the bed manager in the both hospital of the urgency of the transfer and ask if they have any way of creating bed for this patient, for instance by facilitate discharge or rehabilitation of the patient.
Okay, good. Thank you.
Thank you.
Thank you. Thank you, Dr. Sunday. Thank you,
Thank you.
Dr. Mohammed. Yes, it was good. But the
Yes,
problem is a network. You couldn't hear each other in communication that way. So we
exactly.
need to practice more with better communication. Yeah. And this is first time, Dr.
And
Mohammed,
then
you have, yes.
what? Yeah. And one more thing, the reason in this scenario, the reason why you are transferring the patient is because there is no ERCP
In
facility
your,
in your
yes,
hospital. So that's
yes,
what I'm asking. Yeah,
yes,
because the next step in management is to do ERCP, and you don't have it in
yes.
your hospital. That's why I kept asking where.
Where,
So
yes. So
yeah,
he can say it's not available at my place. So that's why I want
yeah,
to transfer it. Yes, good.
exactly.
Yeah, but this was first time Dr. Mohammed presented or tried communication skills, so that's why it will
Okay.
get better.
Okay.
Yeah, with repetition. Thank you so much.
Okay.
Okay, timer has started, and here is your question. Right. If you have read and understood, kindly begin your examination.
So I'll wash my hand.
Yes.
Then I'll introduce myself. I'm Dr. Sunday, one of the
Yes.
surgical candidates. Then I will confirm the patient's name and age.
Yes.
Then after that, I will tell the patient what I'm about to do and take
Yes.
permission. So I'll be informed to, I'll be asked to examine your chest, your heart, and your hand. So it is okay with you? So, and basically what I'm going to do is I'll be looking at your hand, I'll be feeling your pulse, then I'll be
Yes.
listening to your heartbeat and also checking your heartbeat. Is this all right with you? Then I will now ask the patient, before I start, are you in any pain at all? Then the patient position, the patient will be lying supine, semi-supine on the bed. So at about 30 degrees or inclination of the bed, head up. Then I will tell the patient to expose the chest, then and the hand. So that means I can see the whole chest and the upper limb. Then after that, I will start with the inspection. So first I will have to inspect the hand for both fingernails for presence of clubbing, any stick, ecosystem, anything that will show me that the patient is smoking or presence of clubbing or cyanosis. Then after that, I will also inspect the chest also. So, and in this case, maybe I will see left infraclavicular scar. Then, after that, I will proceed to palpation, so which I will feel the pulse. So first on both hands to compare whether both hand radar pulse are symmetrical. Then I will continue on one side. Then after checking for pulse, then I will also check for pulse collapse by checking the pulse while I ask the patient to raise the hand or flex the elbow while extending flex the shoulder joint while extending the elbow, raising the hand up, check if the pulse is going to collapse or not. Then after that, I will feel the temperature in the peripheral, compare both sides. Then after that, then I will now take a look at the face. I will check for the mucous membrane in the eye to check for any sign of cyanosis or paleness. Then I will also, after that, Then I also check the oral cavity. I would like the patient to raise the tongue to the roof and check the oral cavity, the temperature, and any form of a central cyanosis. Then after that, I will check the patient's neck to check for any sign of a maybe jugular distension, jugular vein distension. Then I will check both sides, asking the patient to look on the contralateral side. Then after checking, then after that, I will then proceed to the chest, and I will look at the chest, look for the chest movement, and then I will proceed to palpation of the apex beat on the 5th intercostal space. So I will palpate the apex beat. Then after palpating the apex beat, then I will listen to heart sound. So starting with the diaphragm. So I will start with the apex beat, then which is the 5th intercostal space, just medially to the midclavicular line. Then I will check for the tricuspid valve also, which is on the 4th intercostal space, just to the left border of the sternum. Then I will check for aortic and the pulmonary on the 2nd intercostal space, aortic on to the right and the pulmonary to the left. Then after that, then I will go straight to the carotid artery to check for any carotid root using the bedside of the stethoscope. Then while I'm listening to all the heart sound, I'll be feeling the carotid pulse so that I can determine the S1 level, which sound is S1. Then after that, then after checking carotid pulse, then I will check for carotid root. Then after that, then I will ask the patient to sit down. Then I will not check for accentuation signs. So first of all, I will start with first of all, I will start with the apex beat again, telling the patient to roll to the left side. So, and I will check whether the apex beat is rotating to the axilla on the left side. Then I will also check for the aortic and pulmonary, asking the patient to lean forward for accentuation sign, and telling the patient to take a deep breath and hold in the inspiration. So to check for any form of accentuation, and I also check whether there's any presence of a systolic murmur in the aortic area, and whether it's radiating to the neck. Then after checking that, then I will ask patient that I would like to listen to the lungs, so especially to the back of the lungs. So I will tell patient to sit down so that I can listen to the base of the lungs to check for any presence of crepitude that might show maybe some pathology of the left ventricle or left atria. Then after that, then I will now palpate for the sacra at the back. After the patient, I would like to feel the lower back to check for any form of a sacral edema. Then I will now tell patient that I would like to feel the leg. So I will also palpate the leg tibia to check for pretibial edema, and also squeeze the scarf to check if there's any form of a deep vein thrombosis. Then after that, I will thank the patient. Then I will wash my hand. Then I will summarize my case. So first, I would like to complete my examination by performing a complete cardiovascular examination of the peripheral. Then also check the patient BP, and also maybe perform ECG. Then on this patient today, I examined a 67-year-old gentleman, so who is about to undergo inguinal hernia. So I examined the patient cardiovascular system. So on inspection, there is no obvious deformity of the hand and of the chest and of the neck. Then the peripheral pulse is about 60 beats per minute, and it's synchronized on both hands. So, and the peripheral is warm and there is no open pathology. Then on checking the face, there's no sign of a central peripheral cyanosis also. And on visual examination, I can see that the patient has a left infraclavicular scar, so which is located around the 2nd intercostal space on the left side. Then on auscultation of heart, so I can the heart sound are normal at all points, and there's no presence of murmur, and the intensity is okay, and there's no cardiac trill or any pathology of the heart. Then on auscultation of the lung, there's absence of rales. Then there's absence of sacral and the pretibial edema. So based on my findings, my main
yes, patient is pre-op,
diagnosis for this patient is
scheduled for surgery. So would you recommend the patient for surgery? If you do the ECG of this patient, how would you expect this to be? Can you help me to read this? Yes, please.
So based on the ECG findings, first of all, the arrow is pointing to what we call a spike, pacemaker spike, that shows presence of pacemaker.
Yes.
So Then
What is this circle
yeah, I can see the
indicating?
spike.
Yes. What
And that side indicate the ST depression.
Okay. Can you please name few indications when a permanent pacemaker is indicated?
So indication for permanent pacemaker. So first of all, we have a severe symptomatic bradycardia.
Yes.
So then in a SA node disease, then in cardiomyopathy, eventually dilated cardiomyopathy, end-stage cardiomyopathy, and heart failure. Then some other pathology like long QT syndrome. Then
Okay. Can you tell me why is it important for you to mention pacemaker, and what precautions would you recommend to be taken for a patient who is undergoing surgery and has a pacemaker?
Okay, so why it's important? Because this patient is about to undergo surgery. So we need to first, I need to inform the surgeon, the anesthetist in charge, and also contact the clinic, the company that provide the pacemaker to do pacemaker follow-up pre-surgery to check if the pacemaker is okay. Then during the operation, we need to take some proper precaution by making sure ECG machine is available. Then we can also control the pacemaker, know how to control the pacemaker in case there's any malfunctioning, and also during surgery, the choice of diatomy to use. So it's better we use it's preferable we use the bipolar. So because that will bypass electric current affecting the pacemaker. And if we were to use monopolar, so we need to make sure that the circuit is far away from the pacemaker as far as possible. For example, the plate can be placed on the lower limb, on the limb that is closer to the side of the hernia. So which means the circuit will be far away from even the abdomen, top of the chest. So, and that will avoid the diatomy affecting the pacemaker.
Good.
Then, yeah,
and
then
also,
we can also
yes.
Okay. Then we can make sure that we provide the appropriate resuscitation equipment.
Good.
In the operation room.
Yes, good. Yes, this is very important. Right, good, excellent. Yes. Anyone else want to give? Okay, one question, Dr. Sunday. When you were doing examination or inspection, when you asked to do the lower limb examination and you checked for edema, you could have maybe checked for capillary refill as well.
Okay.
This is one thing that you have missed in your examination. Otherwise, like you have mentioned everything. Yeah.
Thank you.
Good. Thank you. Yes. Started the timer, and here is your question. Right. If you have read and understood, kindly tell me, please.
Yes.
What are the boundaries of or what are you looking at?
So this is a groin region.
Yes.
And we are looking on the femoral triangle.
Yes, very good. So can you please tell me the boundaries of the femoral triangle?
Okay, so the boundaries of femoral triangle, we have superiorly is the inguinal ligament.
Yes.
Then we have laterally is the medial border of sartorius muscle. And medially is the medial border of adductor longus muscle.
Adductor longus, okay, yes.
Yes, so the roof would be the fascia.
Yes.
and the
Fascia lata,
superficial
yes.
inguinal lymph node as well.
Yes, and the floor?
The floor would be the iliopsoas, iacus and psoas, pectinus, and adductor longus.
Okay, good. Can you please tell me what are the structures or contents of the femoral triangle?
Okay, so I will start by the mnemonic navi, so the nerve, femoral nerve from lateral.
Lateral to
Femoral nerve,
medial, okay.
yes.
Yes.
And then we have the femoral artery, superficial femoral artery, and then superficial femoral vein. And then we have inguinal lymph node, the deep and the superficial. We have as well the glissaphenous vein, and we have the lateral cutaneous nerve of the thigh, and we have the femoral branch of genitofemoral nerve.
Okay. Please tell me the most medial content of the femoral triangle is what?
Is the femoral artery, I think.
No.
No.
What is medial to femoral vein, please? Can you identify?
Yeah. Okay. So we have, oh dear, medial to the femoral vein.
Okay, what are the contents of femoral canal?
Yeah, the femoral canal will.
Yes.
The femoral canal will have the lymph node, the cloaket lymph node. There is a fat
And fat. Yes. So
yes.
can you please tell me, yes, what is the purpose of this femoral canal?
So the femoral canal will help the expansion of the femoral vein.
Okay, and
as well for this extent of the lymphatic, inguinal lymphatic.
anything else? Any pathological significance? Pathological significance?
I'm not getting it now.
Yeah. What can happen? How hernia, femoral hernia takes place?
Yeah, true.
Yes.
The femoral, So it is the location of the femoral hernia.
Yes. Yes. So can you please tell me what do you understand by the term vascular lacuna? And there is another term, mascular lacuna. What do you understand by these terms?
Yeah, so the vascular is the sheet which is covering the vessel, lacuna.
Where is it located?
It is in the medial part.
Behind and below the inguinal ligament. It's the vascular lacuna located. So what does it include? What are the contents?
So we know that it is called vascular because it contains an artery. It has got as well the deep inguinal lymph node.
Okay.
And only one branch, it's the branch of the genitofemoral nerve, femoral branch of genitofemoral nerve.
Okay.
And the muscular, this is the, and it hasn't, so the muscular, it has got the femoral nerve then, and it has got the muscle as well, iliopsoas, and as well the lateral cutaneous nerve of the thigh.
Can you please tell me, there is another canal located in the mid-thigh, what does it call?
Adductor canal or
subsartorial canal. Yes, please. What are the boundaries of adductor canal?
So the boundaries of adductor canal, so we have laterally is medialis vastus muscle, and posteriorly is so the adductor longus and adductor magnus, and of course the roof will be the superior part, which will be sartorius. That's why we call it subsartorius canal.
Okay, what are you looking at? What's in front of you? Can you please?
So this is a stereogram of lower limb.
Okay. Can you please tell me, identify the structures? This is medial, this is lateral. What are you looking at? This is A, B, C, and D. Can we?
So A is the popliteal artery.
Okay.
And B, it's the anterior tibial artery.
Yes.
And D, it is the peroneal. So we have the tibioperoneal trunk, which gives D, which is the peroneal artery. Yes. And C, the posterior tibial artery.
And if we are moving on to the right hand side, what are we looking at?
I
Femoral
think it,
arteriogram. Yes,
yeah,
what is
femoral
one?
artery, common femoral artery, and it will give, I think if
What
I'm,
is two?
so it's profunda femoral artery, or
Common femoral artery.
common
Okay,
femoral
three.
artery, yeah.
Three.
This is the circumflex.
Lateral. Okay. And
Yeah, lateral
four,
circumflex.
please. Medial.
Okay. Yeah, medial circumflex artery, isn't it?
And five, please.
Mm.
It's a small one, so it's perforating. Six, please. It's the big one. So
And
what is the branch of femoral artery?
it will continue as
Profunda.
profunda, yeah,
Femoris. Good.
profunda artery.
And what
Femoral
is seven, please?
artery.
Superficial femoral
Superficial,
artery.
yeah, I was guessing it. Superficial femoral artery.
Okay,
Yeah.
can you please tell me how femoral sheath is formed?
The the femoral sheath is the it converts the femoral canal.
Yes, but
So
how
it's
is it
yeah,
formed? It's
extension.
funnel shaped, and then how is it formed?
It's formed from the continuation of fascia,
Yes,
from
transversalis
abdominal, yeah, from
and
the abdominal
iliopsoas
fascia.
fascia. Yes,
Yeah.
and then it's subdivided into how many compartments?
So this is the thing that we were talking about, isn't it? About
Yes,
the
before.
lacuna vascular and the lacuna muscularum.
Lateral compartment,
Yeah.
intermediate compartment, and medial compartment. No, this the
Ah,
medial
no.
compartment contains the femoral canal. This is how it divides into that divides the contents of the femoral triangle into the different
Yeah.
compartments.
So the medial, it will be
Okay,
giving
can you
only the
please
vessel
tell
and
me, please, the surface anatomy of the femoral artery?
okay, the
Where
femoral
would you feel
artery.
the pulse? Yes.
Yeah, we will feel it 2 centimeter.
Yes.
So 2 centimeter below the mid point of inguinal canal, which is
Okay.
between anterior superior iliac spine and pubic symphysis.
Yes. Good. Okay, there are two confusing things you have to remember. Midway between the anterior spheric spine and pubic symphysis and midpoint of inguinal ligament. How would you differentiate it? What is the midpoint of inguinal ligament? Is it the same or is it how
No,
far
I
away
mean
it's?
it's not the same because
Yes.
yeah, because this is where we do it like in to differentiate between midpoint of inguinal canal and mid inguinal point.
Yes. Okay,
So
one
because
last
one is
question. Yes. What is the surface marking of adductor hiatus?
it is along the 2/3 between symphysis pubis and abductor tubercle.
Anterior iliac spine and the adductor tubercle. Yes. Of the
Yeah,
femur.
anterior iliac spine. Sorry, not symphysis pubis.
No.
Yeah, anterior
Yes.
iliac spine and abductor tubercle. Yeah.
Very good. Okay. Good. Okay. Right. I'll read your message later. Okay. Good. Thank you so much.